evening to one and all. I am Dr. Mukesh, Treasurer, Organizing Committee, Thrissur, Kerala, India. I have the proud privilege of welcoming you all to the program of IAP Neocon, Learn from the Legends, an international bi-monthly series. For the fourth webinar of this series, let me first welcome our distinguished speaker of today, Professor Amit Mukherjee from McMaster University, Chair, Prevent BPD Working Group MCH, and Co-Chair of National Lung Health Group of the APIC Canada. Sir, welcome you. He will be talking on non-invasive ventilation and how we view an evidence base. Hearty welcome you too, sir. Next, let me welcome our moderators, Dr. Srinivas Murki from Hyderabad and Dr. Rajesh Kumar from Ranchi. Today we have around 2,500 participants from 44 countries, and I, on behalf of Organizing Committee, sincerely welcome you all for the webinar. Have a wonderful learning experience, and thank you. And one special note, only the 500 members can enter through this link through the email. The others can enter through the YouTube channel. That is, link is already mentioned in the series. Thank you. Over to moderators for the further proceedings.
Thank you, sir, and welcome all the delegates. I think today is a very interesting topic, that is non-invasive ventilation in newborn. We know that one of the commonest reasons why newborns get admitted to the NICU is respiratory distress. And we are now sure that the best modality to treat this newborns with respiratory distress is non-invasive ventilation. And over the years, we have learned the art of NIV, from CPAP to nasal IMV to high-flow nasal cannula. And we have also seen new evidence coming up on the use of nasal HFO. So to deliberate on this important topic, tell us the science, the evidence, and the nuts and bolts of managing a baby with NIV, we have with us Dr. Amit from Toronto. Over to you, Rajesh.
Thank you, Murki. I have the privilege of introducing today's speaker. He is Amit Mukherjee. He is an associate professor of Department of Pediatrics and a staff neonatologist at McMaster University, Hamilton, Canada. He has published more than 20 articles, mostly in the area of neonatal respiratory support. His area of interest is non-invasive ventilation and bronchopulmonary dysplasia. He has formed and chairs the Prevent BPD Working Group at McMaster Children's Hospital NICU. He is also the respiratory lead physician for the McMaster Children's Hospital NICU. He is also the National Co-Chair of the Lung Health Group of Evidence-Based Practice for Improvement in Quality Initiative. I welcome Amit Mukherjee and request to start the presentation. Amit Mukherjee, please.
Thank you very much, Dr. Rajesh, Dr. Mukesh, and Dr. Srinivas for that kind introduction. Also, I want to thank Dr. Manoj and all the organizing committee members for actually inviting me to give this talk. It's actually quite an honor. And also to all the delegates for coming and attending. I hope you find this useful. So I will get started.
Just one introduction, Dr. Amit. All the delegates, please put your questions in the Q&A box and not in the chat box. The questions will be taken at the end of the presentation. So please write all your questions, and then our speaker will help us in answering all of them. Thank you.
Great, thank you very much. Okay, so we'll get started. So I don't have any disclosures or conflicts, but I do have one disclaimer. And the disclaimer is that what we're going to talk about today is really only the tip of the iceberg. So there's, each of the components of this talk today, which we'll cover over the next hour, could be an hour-long talk on its own. So it will be somewhat broad. And certainly, some of the questions that come up, which are maybe more in-depth, we can take during the Q&A session. But what we will cover today is really only the tip of the iceberg. So just to keep that in mind. But with that, The outline will start with talking about how did we end up here? How, like Dr. Srinivas said, we use non-invasive respiratory support, but what's the evidence to support the increasing use of it? So we'll touch on that for the first component. Then we will talk about the different forms or modes of non-invasive support. And I've chosen the 4 more common ones that are utilized. So CPAP, NIPPV, high flow, and nasal high frequency. And at the very end, I'll leave you with some practical considerations on how to apply these different modes in your own unit. So we'll start with the first component. So why non-invasive respiratory support? So at a very basic level, I think most of us know that it is associated with less volume trauma and less barotrauma. It can be associated with avoidance of cardiovascular and cerebrovascular instability that's related to intubation and the procedure itself. We also know that long-term intubation and mechanical ventilation can lead to subglottic stenosis and tracheal lesions, so using non-invasive support avoids that. And also avoiding morbidities like ventilator-associated pneumonia. And all of these things, when we avoid them, we generally refer to the term ventilator-induced lung injury, and the use of non-invasive respiratory support can avoid what's called ventilator-induced lung injury. But let's look at some of the evidence base around that. So we'll start with some animal studies, and be aware that there are many animal studies to report on things like these. So what I've chosen is really the representative studies, but there are many more examples of studies like this. So this is from Alan Jobe and his group in Ohio. And what they did is they took preterm lamb model, and they took these preterm lambs and they divided into groups which received no ventilation, some that received CPAP only from birth, and those that received invasive mechanical ventilation. And they tracked the progress of these lung characteristics over the next 2 hours after the lambs were euthanized. Now, what they found is that during the 2 hours when the lambs were ventilated, the CO2 levels were better controlled, I should say, in the ventilated group, because they could get the CO2 to their target range of about 40 millimeters of mercury. So the CO2 level in the CPAP groups was a little bit higher, but that's not surprising. However, after the lambs were euthanized, what they did find is that in the open circles, these are the lambs who were ventilated. And what they found is that in the pressure volume curve, for a certain pressure, the lambs that were ventilated actually has less volume than those lambs that maintain CPAP. So arguably suggesting that for the same pressure, you can get better lung inflation when those lambs were only exposed to CPAP, giving you a hint that those lungs were in better condition after the lambs were euthanized. They also looked at inflammatory markers and found that things like hydrogen peroxide and neutrophils were actually much higher in the lambs that were ventilated compared to those that underwent CPAP or those who were not ventilated at all. Similarly, a study from Thompson et al. In pediatrics from 2006, they took the preterm baboon model and they divided the preterm baboons into 2 groups. One that were extubated early to CPAP on day 1, and there were others that were delayed extubation until day 5. So they had 5 days of mechanical ventilation before extubation to CPAP. And all these animals were treated similarly and what we would consider generally lung protective mechanisms. So all these baboons were given prenatal steroids. They were all given exogenous surfactant, and they underwent lung protective ventilation with tidal volumes between 4 and 6 mils per kilo, and an initial CPAP level of 7 centimeters of water. So that's pretty much what we would do in a modern NICU. But here's what they found. So when they looked at the FiO2 level here on the right, on the x-axis, and they tracked these babies these baboons for 28 days. And what they found is the FiO2 requirement to maintain their oxygen in the normal range was actually lower in those babies that went early extubation. So the solid line here represents early extubation, and you can see that the FiO2 requirements were much lower in those groups that compared to those that went delayed extubation to CPAP, where their FiO2 needs were actually higher. A similar trend is noted in the CO2 group. So you can see here again that the PCO2 was actually lower, meaning that the lungs were able to better ventilate in those that went early extubation to CPAP up until almost 28 days, as compared to those who went delayed extubation to CPAP. when they looked at the arterial alveolar ratio, so again, the higher the number is, the better it is, because the more oxygen can transverse over that alveolo-capillary membrane. And you can see again that those preterm baboons that underwent early extubation to CPAP had a higher arterial alveolar ratio of oxygen compared to delayed CPAP. They also looked at the lung characteristics on the pressure volume loop using static compliance curves, and found that compared to a term, so the term is represented in the triangle, which is this curve here, that the early extubation to CPAP actually approximated what the pressure volume loop for a term baboon would look like. And on the other hand, those that had a delayed extubation to CPAP showed poorer compliance and overall a lower hysteresis curve and a lower volume at each pressure point compared to those that underwent early CPAP. So this is all giving us a clue from animal studies that the early use of non-invasive respiratory support and minimizing the duration of invasive mechanical ventilation yields improved and better lung characteristics in these animal lung models. So now and sorry, one more thing, yeah. So there is also, similar to Alan Job's group, they also found that inflammatory markers, and in particular, we're looking at neutrophils, were actually higher with the delayed CPAP group compared to early CPAP group. So that's the evidence from the animal study. So we'll now start to look at some clinical data around this. So this is a bit of an older systematic review and meta-analysis from Fisher and Lurer. And what they found, and what they did, is they looked at a number of studies that were designed to minimize invasive mechanical ventilation early on, post-resuscitation. So some of these were trials like COIN and SUPPORT that many of you are aware of, but also included things like AMV and the Take Care trial, which are designed to look at LISA or MIST, or less invasive surfactant administration, to avoid mechanical ventilation altogether. So they pooled these different strategies that tried to avoid invasive mechanical ventilation altogether. And in their forest plot, the pooled estimate of BPD or death was actually significantly lower when strategies are used that avoid mechanical ventilation. And the primary outcome here was BPD or death. A different kind of systematic review that only focused on early CPAP use versus routine intubation. So this is from Georg Schmolzer, who's one of my colleagues in Edmonton, and his group. And what they found is when they combined, the studies, including the COIN trial and SUPPORT trial, and looked at the combined outcome of BPD or death, they did find that the pooled odds ratio was significantly lower, favoring the use of nasal CPAP as the initial mode of respiratory support compared to routine intubation. Similarly, when we look at the individual components of those outcomes, so looking at death and BPD, there's a signal towards it being favoring nasal CPAP. However, neither of these ended up being statistically significant, but you can see that it trends towards favoring nasal CPAP use as the initial mode of support. So all of this led to the American Academy of Pediatrics a number of years ago now to say in their policy statement that CPAP started at or soon after birth with subsequent selective surfactant administration may be considered as an alternative to routine intubation for preterm babies. And even though what I've shown you so far, and most of the clinical data exists to date, is really around how to manage babies in the immediate postnatal period, post-resuscitation, we have seen a paradigm shift in neonatal respiratory support. And as was said during the introduction, that we now see most of our babies in our unit on nasal respiratory support or non-invasive respiratory support, as compared to a decade or more ago, where many of our babies would be on intubation and mechanical ventilation. And we take these principles we've learned from the animal studies and from human studies, and we apply them to all aspects of neonatal care and really try to minimize invasive support as much as possible. So some real world data on has practice changed? And this is from the Canadian Neonatal Network. It's a little bit outdated now. On the x-axis, we have 2010 all the way up to 2017. And on the y-axis is the percentage of patient days on respiratory support. So any patient day on any kind of respiratory support, and what percentage of that was in non-invasive form. So back in 2010, if you looked at all preterm babies or all babies admitted to NICUs in Canada, about 50% of respiratory support was in the non-invasive form. But now in 2017, that's upwards of 65% and now probably approaching even 70%. So we've seen a dramatic increase in how much we're using non-invasive support, at least in Canada. And there are similar reports, survey-based, that look at, that comment on the widespread use of different non-invasive support modes in other countries as well. So that concludes the first component of our talk, and hopefully I've given you a little bit of taste of what the evidence is out there that supports why we use non-invasive respiratory support to the extent that we do now in modern neonatology. So we'll now talk about the different forms or modes of non-invasive support and focus on those 4 different modes that I mentioned previously. So this leads to our first survey question. So I don't know if the survey question can be brought up. So which of the following NRS modes are used in your unit? So nasal CPAP, NIPPV, non-invasive high frequency, high flow nasal cannula, and then we have combinations, which are A and B only, A, B, and C, A, B, and D, or all of the above. Okay, and we can look at the poll answers here. Yeah, so not surprised. I think the majority of people, 47% of respondents say that nasal CPAP and NIPPV and high flow nasal cannula are used routinely in their unit. Interesting to know that nasal high frequency is not used at all. And some respondents have included nasal high frequency, so A, B, and C. So 3% said CPAP and NIPPV and nasal high frequency are used, and 19% have said all of them are used. So it is used. So it looks like all the modes are being used at most of your centers, but there is some variation, as you can see. Here's the second question. So a 28-week gestational age neonate is just delivered by vaginal delivery after spontaneous onset of labor. Antenatal steroids were given 3 days ago, so appropriate coverage, and the baby is adequate for gestational age. Required PPV for 2 minutes via TP's resuscitator, but is now stable. What do you choose next as a starting point? So A is nasal CPAP, B is NIPPV, C is nasal high flow, and D is intubation and mechanical ventilation. Okay, so we'll look at the responses now. So the vast majority would start with CPAP, and I think that is many people's experience. However, it's interesting that many people would actually start with nasal CPAP, and some would even go to nasal high flow, and some would intubate. Obviously there's no correct answer here, but this is just to look at what the practice is for all of us to know what others are doing, and I think there's views in that. So we'll start talking about the different modes, and now this is a schematic that I quite like from Mahmoud et al. From a number of years ago now, that really puts the different modes of non-invasive respiratory support in a pictorial context. Now, the one thing that I'll ask everybody to take away from this talk is that we're really trying to minimize the use of the term non-invasive ventilation, because non-invasive ventilation can mean different things to different people, because some people will use the term non-invasive ventilation to refer to what I'm going to talk about today as NIPPV. So I find that the term non-invasive respiratory support is a more general term, and it's probably less confusing than using NIV. With that in mind, we'll just highlight the 4 different modes that we're going to talk about today, and then we'll start with CPAP. At a very basic level, I think this will be familiar to all of you in the audience, that pressure is flow times resistance, and that's what CPAP is doing. It's generating a pressure at the nasal interface, but with a combination of how much flow is going through the circuit and the interface, and how much resistance is generated in whatever mechanism is used to generate that resistance in the system. And I'll use a very basic bubble CPAP model to illustrate the 4 components that you need to deliver CPAP. So one of them is you need a gas source with oxygen blender to actually provide the gas flow. You need some kind of a patient nasal interface, and today we're not going to talk about the different types of interfaces. That's a different talk on its own. We also need a ventilation circuit of some form, and you need some way of generating a pressure mechanism. So in the case of bubble CPAP, all that's done is the expiratory limb is inserted into a column of water, and the deeper you insert that column into the water, the greater the resistance, and therefore the greater the pressure generating mechanism is. Similarly, the more flow you give, the more pressure we're going to generate at the level of the nasal interface. So those two components really determine how much pressure is generated. And of course, you always need this to be heated and humidified, and that's what's shown here. And also, all of you know, CPAP generates a constant distending pressure at the level of the nasal interface, and replicates the natural physiological reflex of grunting to help maintain adequate lung volume, particularly in situations when the lung has this tendency to collapse, as in the situation of RDS. And the baby would normally generate his or her own glottic pressure to counterbalance that tendency to collapse, and CPAP is just recreating that. And CPAP is really still considered the most prototypical, and it was evidenced by the survey, still the most commonly used, and it is the best studied of all the different NRS forms. So there are various forms of CPAP, and I won't go into too much detail, but it can be subdivided into a constant flow CPAP, a variable flow CPAP, and the constant flow CPAP can be given through a ventilator, a conventional CPAP, or it can be given through a bubble CPAP setup. And that's illustrated in this diagram here. So you can have continuous CPAP given via, for example, the Babylog 8000 as an example, a bubble CPAP setup. And variable flow CPAP, and this is one example of it, is the infant flow device, CPAP device. But there are many other forms of that as well. So it leads to our next survey question. So which of the following types of CPAP has been shown to improve long-term outcomes? Is it ventilator-based CPAP, infant flow CPAP, bubble CPAP, or there's no difference shown? Again, for long-term outcomes. Okay, so we'll open up the responses. Yeah, so this is interesting. So we, bubble CPAP does have a lot of, evidence behind from centers that use it quite routinely who have good outcomes. But I'm going to come to this in a few minutes, and I think the answer will become a bit more clear to you. The bottom line is that in terms of long-term outcomes, there's no difference between any of these CPAP modes. And we'll touch on this a little bit. I do want to mention briefly variable flow CPAP devices because it's a little bit distinct from how the other CPAP devices work. And again, if you use a variable flow CPAP device in your unit, it would be important to know in detail how the mechanism works. So this is using the infant flow device as an example. And what they have here is the inspiratory gas flow. There's a column that actually monitors the pressure within the interface, and there's the expiratory channel. And what's unique about the variable flow CPAP devices is that during inhalation, the gas flow will happen and will push the gas towards the patient interface. Whereas during exhalation, when the baby is breathing out, the gas flow will actually revert over and go towards the expiratory column. So when the child's breathing out, you don't have this flow of gas going towards the baby. And there's mechanisms behind that called the Coanda effect, and you can read about this in more detail. But it intuitively makes sense, and it's supported by evidence that these variable flow CPAP devices may lead to reduced work of breathing compared to a continuous flow device. But there's no evidence, again, of any differences in long-term outcomes. Now, coming to bubble versus other forms of CPAP, I think this based on the survey question, there is no a belief out there that bubble CPAP may be superior, and certainly centers who use it a lot have very, very good experience and outcomes with it. So we actually had done a systematic review that we had published earlier this year, looking at bubble versus all other forms of CPAP, and we did find that there's a lower risk of CPAP failure when we looked at bubble CPAP versus all other forms of CPAP pooled together. And that's shown in this the forest plot here, and you can see that the pooled odds ratio does favor bubble CPAP in terms of CPAP failure, but we did not find any difference in short-term clinical outcomes such as mortality or BPD. Now, in terms of the clinical use of CPAP, there are many indications, of course. So our survey question talked about the primary respiratory support after you've just helped the baby transition. So that certainly could be one indication. There are a number of other indications that are all listed here, which I'm not going to read in detail. And also, CPAP can be used as a post-extubation support mode. So maybe those three different, three big categories of indications could be considered. Now, another question I'm going to ask everybody is, what is the maximum CPAP pressure employed at your center? So is it less than 8 centimeters of water, 8, 10, 12, or greater than 12 centimeters of water? Okay, and we can look at the responses. So as you can see, the vast majority of respondents are using either less than 8 or 8 centimeters of water, accounting for about 85%, and the remainder are using a little bit higher than that. And that's something that we see quite routinely, and I'm going to explore that a bit more. But since we're talking about CPAP, one of the things I want to point out is that centers are increasingly using higher than 8 centimeters of water CPAP pressure. And this was a survey that we had done in Canada a number of years ago, and as you can see, of the 28 responding centers, 5 of them had said that they were routinely using a maximum CPAP of 10 or higher even, whereas there were some that were using, kind of similar to what the audience response was today, 8 or less. But the use of high CPAP is becoming increasingly common, and it's partly because the ventilators that we use nowadays to deliver CPAP can be made to deliver higher than 8 centimeters of water. Well, we've done some work at our center looking at high CPAP use and cardiac output. So this was, we had published this last year, and we took babies on CPAP of 5, and we, for a brief period of time, put them up to CPAP of 13 in increments, as you can see here. And we looked at the cardiac output in mils per kilo per minute. As you can see, in this group of relatively healthy babies, even going up to CPAP of 13 for a brief period of time did not significantly alter the cardiac output. We also looked at the left ventricular output during CPAP and NIPPV when given that equivalent mean airway pressures. And the importance of this will become clear in a little bit of time, hopefully. But we did find that when we took babies on high CPAP and converted them to NIPPV, and also vice versa, took babies on NIPPV and converted them to CPAP, and compared their left ventricular output, we found that there was no difference between the two in echocardiography. Now, I just want to leave you for CPAP with how we use it at McMaster. It doesn't mean that that's the right way to use it, or there's only one way to use it, but I just want to illustrate the guidelines as to how to use CPAP. And one of the things I just want to highlight is that CPAP is our mode for extubation. So any baby that's extubated, we first start them on CPAP. So that's one kind of thing that we've decided upon locally. And also we have agreed upon the range of settings. So in the acute phase, which is the first 7 days of a baby's life, we allow between 5 and 8. And in the chronic phase, which is after the first 7 days of life, we routinely will allow between 5 and 10. And in rare circumstances, we may go even above 10. So that concludes the section on CPAP. So I will move on to the next section, which is NIPPV. So NIPPV, again, this will be familiar to most of you in the audience. It combines the constant descending pressure with superimposed ventilator-delivered breaths at a set peak pressure and regular intervals, all given via a nasal interface. And it's really trying to mimic what conventional intermittent mandatory ventilation does. And as you can see here also, that by virtue of having a peak pressure and a constant descending pressure in the background, we do generate a mean airway pressure that is a weighted average between the top and the bottom pressure. And the PIP, PEEP, rate, I time are all set by the user of the machine. Now, there are some NIPPV subtypes that are worth mentioning. So you can have NIPPV, and some people consider biphasic CPAP to be a form of NIPPV. Those of you familiar with Harish Kripalani's NIPPV know that in NIPPV also was a mix of NIPPV and also biphasic CPAP. NIPPV can also be synchronized or not synchronized, and I'll touch on that briefly. And a newer mode that many of you would be familiar with is something called newly adjusted ventilation or NIV-NAVA. So to touch briefly on NIPPV and biphasic CPAP, this image actually illustrates the difference between them well. So NIPPV is really intended to mimic tidal ventilation. So it has relatively shorter I times and higher peak pressures, whereas biphasic CPAP conceptually could be understood as simply 2 levels of CPAP, and the baby is allowed to breathe spontaneously around what is essentially 2 different levels of CPAP. So the quote-unquote I times are longer, and and the peak pressures are generally lower than what we give during traditional NIPPV. But sometimes there's a bit of a gray zone between these two modes, and you may have a combination of settings which is kind of in between biphasic and CPAP. Now, in terms of synchronization, over the years, there have been various methods to try and synchronize, these breaths with patient's efforts. So in the past, the Graysby capsule has been used, which tries to look at the abdominal, movement and try to time the breath delivery with that. Ventilator companies have also used flow sensors and other types of devices to try and pick up the baby's breath and give the breath at the same time. But it's uncertain as to how reliable some of these synchronization efforts are. Now, to that end, one of the promising ways to synchronize NIPPV would be to use neurally adjusted ventilatory assist. Now, to understand this, the way this works is that instead of a regular feeding tube, we put in what's called the EDI catheter, so which measures the electrical activity of the diaphragm. And what this catheter has, that along with the ability to feed, it has a separate system that actually measures the diaphragmatic signal using a number of electrodes that are placed just above the end of the catheter tip. Now, normally, as everybody knows, the central nervous system will, through the phrenic nerve, lead to diaphragmatic excitation, which then leads to diaphragmatic contraction, which will then result in chest wall and lung expansion. That will then lead to, because of the pressure gradient, lead to an airway pressure, flow, and volume at the level of the patient's nose. And that is normally picked up as a flow trigger during conventional mechanical ventilation, and also some of these ventilators that try to do NIPPV in a synchronized manner. And that's what leads to the assisted breath from the machine during a conventional intubation mechanical breath, or NIPPV in some cases. But what happens with NAVA is that it's the diaphragmatic excitation that's actually picked up by this catheter in a fairly reliable way compared to the flow trigger, and particularly with NIPPV, which can be not so sensitive. But the neural trigger will be sensitive and will reliably let the ventilator know that the baby wants to take a breath because there is an excitation at the level of the diaphragm, and that will lead to an assisted breath. So this is actually a promising way to deliver synchronized NIPPV. And there is a nice reference here for anybody who's more interested in looking into this more. And a recent Cochrane review published just in 2020, illustrates that there's actually still a lot of work that needs to be done to kind of show the clinical impact of it, but that the studies are actually starting to emerge. And in this one, based on one RCT, there was a lower risk failure of the modality compared to other non-invasive respiratory support modes, whereas the NIV-NAVA had a significantly lower failure rate. But in terms of respiratory failure, CLD, mortality, all those other outcomes, we still need an evidence base to show the true impact of NIV-NAVA. So that's all I'll cover about that. That again, it was another topic that's a talk on its own. So again, it's be somewhat superficial in that regard. But we go back to regular NIPPV. And it's supposed to mimic and augment tidal ventilation, as we mentioned, but others have proposed a variety of other suggested mechanisms of action. And the truth is that nobody really knows with certainty what the mechanism is. But despite the purported mechanism, there's actually very limited evidence that there's good tidal volume delivery in a consistent manner with the use of an NIPPV. So Louise Owen has written and done studies on this, and she says that the delivered peak pressure is actually quite variable and considerably lower than what we set at the machine end. And that's natural because we know that a lot of it will leak out of the baby's mouth. It's also known that the majority of NIPPV breaths are maybe asynchronous, and when they do coincide, the tidal volume delivery may only increase by 15% in some instances. And when looking at studies comparing CPAP with synchronized NIPPV, the consistently increase in tidal volume has been failed to be demonstrated. So there's some limited evidence for tidal volume delivery, but it's not to say that it doesn't happen, but it doesn't happen as reliably or consistently as it does during invasive mechanical ventilation, and that's an important thing to keep in mind. So all of this has led people to ask the question, are there instances where it's simply that NIPPV is increasing the mean airway pressure, and that's the mechanism by which we see some of the clinical benefits, rather than any true NIPPV specific mechanism of action? But this question till date remains unanswered. To what degree these two different factors play a role in an NIPPV. But despite those limitations, we do have indications for NIPPV. So you could be used as a primary mode of non-invasive support, like some of their survey respondents said they do. It could also be used as a post-extubation mode of respiratory support, and we'll get into that. And oftentimes it's used as a rescue mode following failure of CPAP. And at our institution at McMaster, that's how we largely use an NIPPV, as a rescue mode. Now, the evidence for primary non-invasive mode of use of an NIPPV comes from this fairly recent, from 2016-2017 Cochrane review that Brigitte Lemire, one of my colleagues from Ottawa, had done. And in this one, there were about 1,000 infants with early NIPPV versus CPAP shortly after birth. To keep in mind that this included studies where some or all patients were intubated briefly for surfactants. So not all the patients here are those who were directly placed on an NIPPV. Some had been given surfactant already. And the outcomes are here as follows. So respiratory failure, need for intubation, and chronic lung disease was seen to be lower when these patients were started with NIPPV compared to CPAP. When looking at NIPPV as a post-extubation non-invasive mode, again, another Cochrane review looks at this by the same group, this time about 1,500 infants. Again, NIPPV versus CPAP post-extubation, and again, included studies where some or all patients received synchronized NIPPV. So the NIPPV group was a little bit heterogeneous. And again, respiratory failure, need for intubation, and pulmonary air leak was found to be lower with the use of NIPPV compared to CPAP. So based on these Cochrane reviews, actually, we noted that in Canada, the practice changed quite a bit. There were many centers that actually started using NIPPV, both as a post-extubation mode and also as a primary support mode. However, despite the findings, there are some considerations to keep in mind. The first consideration that I'll leave everybody with is that the CPAP levels in these studies that were included in the Cochrane reviews were actually lower than oftentimes what many centers are using. So for instance, if you are a center that uses routinely CPAP pressures above 8, then these findings may not apply to you, may not be as applicable to you, because as you can see here, some of these studies only limited CPAP pressures up to 5 or 6, while some others went to 8. And as you can see from or derived from the NIPPV settings, so the mean airway pressure would often be much higher than what was delivered on CPAP. And the same thing goes for the other Cochrane review that looked at NIPPV in a post-extubation manner also. The second thing to consider is that in all of these studies, when CPAP failed, these patients were intubated with very limited rare exceptions. And that is very different than our modern clinical practice where if CPAP doesn't work, for reasons that were mentioned before, we try to keep these babies on non-invasive support. So if CPAP doesn't work, most centers will try to rescue them with some other form of non-invasive support. So in that sense, also, there's some limited generalizability of many of these studies to our modern clinical practice. So those are just some considerations to keep in mind. But nevertheless, when purely comparing CPAP and NIPPV used in the way that they have used in the study design, NIPPV did show to be superior to CPAP. Now, one question that comes up quite a bit is, what about NIPPV for use of apnea or prematurity? And this was one of our students from McMaster, and this is currently under review at a journal. We looked at the frequency of apneas when NIPPV was used versus CPAP. And as you can see here, when we looked at the frequency of apneic events, we found actually no difference between NIPPV and CPAP from these 8 studies that were included for this particular analysis. But then when we looked at the presence of any apnea, granted over varying periods of time, we did find that NIPPV was favorable over CPAP for this purpose. However, there were many limitations in the included studies, one of which was quite variable use of NIPPV, and secondly, quite variable definitions on how apnea was actually measured and diagnosed. So because of those limitations, we did conclude that we need prospective studies with firm definitions of apnea before NIPPV can be routinely recommended as a treatment for apnea prematurity. So coming back to the NIPPV specific mechanisms of action, people have actually said that future NIPPV research needs to assess the impact of NIPPV while correcting for MAP, or the mean airway pressure. some people will ask, well, NIPPV does seem to have a signal for improved outcomes, so why not just always use it? Why don't we just abandon CPAP and always go to NIPPV? But so while there is some evidence to support that it may be beneficial and there's no consistent reproducible risk of harm, there are some unknowns with NIPPV that I just want to highlight over the next few slides. So I'll first start by asking the survey question. So again, there's a 28-week gestational age baby that's now 14 days of life on CPAP of 7. Due to recurrent apneas, the decision was made to try NIPPV with a PEEP of 7 and I time of 0.5 seconds. So if you were the person making the decision, what would you choose for the remaining settings? A PIP of 12, rate of 40, B, a PIP of 14, C, a PIP of 16, D, a PIP of 18, or E, none of the above. Okay, we'll look for the responses. Again, there's no correct answer, but as you can see here, there's considerable variability in what people would choose as even the starting point. So I think which highlights the wide range of PIPs that are often used with the use of NIPPV. So again, the most effective and safe peak inspiratory pressures actually still remain unknown. And that this has led to significant practice variation that was illustrated in the survey question that we just looked at. And we had asked practitioners in Canada, so each center, to ask what maximum peak inspiratory pressure would you ever use during NIPPV? And as you can see here, the maximum PIP ranges anywhere from as low as 12 to as high as 25. Again, illustrating quite a bit of variance in how NIPPV is used. And there's also some evidence from animal studies that going too high on PIPs may actually be detrimental and may induce glottic closure and result in diversion of gas to the GI tract. And this is a clinical issue we face quite a bit, at least in our unit, where babies on NIPPV sometimes will have distended abdomens and some feeding issues. And where that balance is between a PIP that will ventilate effectively, but then also not lead to gastric distension, sometimes it remains a bit unclear. And also it's unclear whether the same benefits will be seen if we simply use high MAPs on CPAP or another non-invasive mode. So because of some of these uncertainties and limitations in our understanding of NIPPV, I think many centers are not routinely using it in place of CPAP because many babies, frankly, will just tolerate CPAP quite well and not need any further escalation to NIPPV. Now, despite the limitations on NIPPV, Vineet Bhandari from a number of years ago, actually, he had published what would be suggested settings for use of NIPPV. So when used as a primary mode, so you're starting a baby post-transition, post-resuscitation, these are the suggested settings. So frequency of 40, PIP 4 centimeters above whatever the PIP was required during handbagging, let's say, and a PEEP of 4 to 6 with night time of 0.45. And when used as a post-extubation mode, the suggested frequency, Vineet said, was between 15 and 25, PIP 2 to 4 higher than whatever was on conventional settings, and then to adjust the PIP for effective aeration based on auscultation, and a PEEP 5 or less. Now, I will be honest that modern use of NIPPVs and sometimes may vary quite a bit from these suggested settings, and these may be starting settings you may begin with, but then often you have to adjust those settings. And the optimal way to use an NIPPV still remains unknown. And Vineet actually mentioned that in his article, that these are based on very limited evidence. The optimal strategy is to be determined. Despite those limitations, we have at our own unit come up with some suggestions for how we're going to use CPAP. Again, we've made it clear that we don't routinely extubate to CPAP, but so NIPPV, we instead routinely extubate to CPAP. And then if the baby doesn't do well on CPAP, we go to NIPPV. And we almost never use NIPPV at our center before we give surfactant. Now, it doesn't mean that that's the right approach or the wrong approach, but I think in the face of some limited evidence, we just wanted to have a unified practice at our center so that at least we know what is it that we're doing. And here are the range of settings that we typically will allow for when using NIPPV. And all of our non-NIPPV use is non-synchronized NIPPV. Okay, so with that, we'll move on to high flow. High flow, I think, again, all of you are familiar with, but the reason for its origins really came from complications with CPAP and NIPPV. And we've all seen images like this where the nasal septum and mucus is quite damaged. There's also reports of air leaks, increased thoracic pressure, abdominal distension. All of these things have been reported with other non-invasive support modes. And nasal high frequency cannula was actually first introduced in the early 90s, but it fell out of favor until its reemergence about 10 years ago. And we know that it's easier to apply than CPAP. It allows for greater access to the baby's face, which may improve feeding and bonding. And again, many centers actually feed on high flow, whereas they don't do so on CPAP. It's also less prone to nasal injury, and that has been shown in many studies that have been done on nasal high flow. And it does improve nursing and parental satisfaction. And you have a baby that looks generally much happier, as you can see here on the picture, than CPAP. So next survey question is, what is the mechanism of action of high flow nasal cannula? Is it washout of CO2 from anatomical upper airway dead space? Is it generation of positive distending airway pressure? Both A and B, other mechanism, or unknown? Okay, and we'll open up the responses. And again, so I think most of you have it right, that both washout and generation of positive descending pressure are believed to be mechanisms of action for high flow, along with some others that have been suggested. But the underlying ones and the ones that everybody answered is supposed to be, are believed to be the main mechanisms of action. We won't have time today to go into things like how much distending pressure is generated and so on. So we'll leave that for another time or for a different talk that you guys may have. But from Cochrane review, looking at the clinical evidence behind the impact of high flow, it is believed that it has similar rates of efficacy to other forms, but there are a few caveats. There's very limited data in preterm babies who are less than 28 weeks till date. And also, I would say somewhat limited data in preterm infants between 28 and 32 weeks gestation. And up until the time of this review, most of the evidence was still with the use of high flow as a post-extubation support mode. And that's where the initial studies on high flow done by the Australian group were done. Now, a few years later, the same group published the use of high flow therapy for primary respiratory support in preterm infants and compared to CPAP. And in this study, they actually concluded earlier than the study was supposed to be finished, that as you can see here, that the treatment failure was consistently higher with the use of high flow compared to CPAP, no matter which gestational age group they looked at. So it became clear that when used as a primary support mode, that high flow had a higher rate of failure compared to CPAP. Now, that's just a bit of a flavor for the existing evidence on high flow, but a few years ago now, a group from the US, Australia, and other countries got together, and they actually came up with consensus-based guidelines on how to best use nasal high flow therapy. So I'm going to leave this here with you, but as you can see here, some of the important things that are highlighted is that the maximum allowed flow is 8 liters a minute, and that's because the vast majority of the studies that have been done on high flow in neonates go up to 8 liters a minute. Now, Brett Manley and others have talked about doing studies where they go to high flow higher than 8 liters a minute, and I think those will come in the next few years. But for now, the existing evidence only goes up to 8 liters. And if you were to exceed those flow limits, that needs to be discussed within your unit. General agreement on initial flow rate was somewhere between 4 to 6 liters a minute. And there's no consensus on how to best stop nasal high flow. So whether we should stop at 5 or 4, or should we kind of wean them slowly, and whether one approach is better than the other as yet remains unclear. Some of the other recommendations out here are highlighted. I'm going to highlight this later on as well. But the preferred cannula to nares ratio is 0.5, meaning that we don't want these cannulas to occlude the nares, but rather leave about half the nares open to allow for that washout CO2 mechanism that we talked about earlier. And again, this is not for everybody to read, but just to know that we do have a policy for high flow at our unit, and we do not use it for babies at this point less than 32 weeks, but in the coming years, we may change our practice on that. And again, the important things, once again, to highlight is that the prongs really shouldn't occupy, or try not to occupy, more than 50%. And to facilitate that, we try to use an orogastric tube and not a nasogastric tube as much as possible to leave the nares patent and open. Okay, and finally, we'll talk about nasal high frequency. So nasal high frequency is the administration of high frequency via nasal interface, as the name suggests. And the idea behind this, when it first came out more than 20 years ago, was really to take the benefits of high frequency ventilation and combine that with the advantages of non-invasive respiratory support. And as illustrated in this figure, compared to the NIPPV pressure curve that I showed you before, high frequency is simply doing that at a much more higher rate or more frequent rate. And the mechanism of action, one of the concerns that has been brought up from earlier studies is that whenever a study on high frequency was done, there was a higher constant mean airway pressure used. And that has led to the question that is it just simply that we were using higher descending pressures, and that's all it was, and not the high frequency component itself. But there's a presumption that otherwise whatever mechanisms operate during invasive high frequency, and for anybody who's interested in reading more about it, this is a classic paper that goes through the different types of supposed mechanism of action for high frequency. We do believe that some of those same mechanisms are also at play during nasal high frequency. I'm going to show you a video of a patient from our unit that was placed on nasal high frequency. So we use a ventilator that we use for all our other purposes, the Draeger VM500. This is a prong similar to the Hudson nasal prongs, so short binasal prongs. And one of the things you'll notice is that we do put like a sandbag, so like some kind of a heavy bag around the baby's head, so that we take away or we attenuate the shaking of the tube, because there is some shaking of the tube that occurs, and some of the amplitude or the power is lost with the shake of that tube. So we do try to keep the least amount of tube free within the incubator, and also to put a heavy sandbag around the baby's head. So we want to minimize how much shake there is at the nasal interface, because we worry that a lot of shake at the nasal interface can start to damage the nasal mucosa. And also we don't want the baby's head to be shaking a lot. But as you saw there, despite those settings, an amplitude of 28 and a frequency of 10, you see that there's very minimal shake of the nasal interface. But yet, we're able to transmit some of that high frequency amplitude over to the baby's chest. And I'll get into that in a little bit. As you see here, this baby was actually quite unwell. The FiO2 was 70%, the MAP was 16. And this baby did eventually get intubated, but I just want to show you an example of a baby in whom we tried this to try and avoid intubation and mechanical ventilation. This is another video. I'll just quickly leave that on again, showing you again, you do see some of that shake within the incubator even, but by the time it gets to the baby's face, there's actually not that much shake of either the interface or the baby's head. Okay, so we'll move on to, when is the time that you may use nasal high frequency? So people have reported and are studying the use of nasal high frequency as a primary mode of non-invasive support. So right after transition or resuscitation. There are also studies and clinical use of it as a post-extubation support mode. And at least at our center, when we do use it, we commonly use it as a rescue mode when other forms of non-invasive support have failed. But this is the area that's actually the least studies exist, or least amount of data exists to support its use that way. So when looking at its use as a primary support mode, these are the papers that exist on it till date, till as of a few months ago. And again, showing earlier recovery of symptoms in TTN, lower probability of intubation, fewer days of respiratory support, and again, lower incidence of need for intubation. And again, these studies are still kind of somewhat small in size, with the usual biases of unblinded studies that exist, and with some generalizability issues still. So it's not to say that the findings from these studies can be interpreted as being definitive findings. I think there's a lot more work that needs to be done to conclusively prove the optimal or the best way to use nasal high frequency. But this is what's coming out from the literature in recent years. When looking at its use as a post-extubation support mode, we had an observational study a number of years ago, and we did find that we were able to avoid invasive ventilation in more than 50% of those cases, and where we used it as a post-extubation support mode. And again, other studies have reported, observational studies have reported similar things. A study from China that was an RCT did suggest a lower probability of intubation when used as a post-extubation support mode compared to CPAP. When used as a rescue mode, and I think this is one of those things that's a little bit, harder to study because you have limited patients to study this kind of thing on, but arguably the benefit may be more in these kind of cases. But here's the data that exists to date. So as you can see here, it's very limited numbers, 21 babies, 58 babies from our group a number of years ago, and then 28 babies, all observational in nature. So very limited data to kind of support it in this kind of a scope. And those of us who've done a little bit of work on this do suggest this kind of settings, that we use an initial mean airway pressure equal to or 1 to 2 centimeters higher than whatever the previous NRS mode was, but recognizing that the safe and upper effective limit remains unknown. We do suggest a frequency of 10. At our center, we'll start around 10 and then adjust it up or down based on how much the baby's shaking. And then the amplitude, we generally will set it so we can at least palpate or see a visible chest shake, and using strategies to make sure that the baby's head is not shaking too much. But again, to all of this with the caveat that the optimal choice of settings is still remains unclear. And again, just to illustrate to you that we do have a guideline at our center that we use. And again, I'm happy to share these guidelines with anybody who may be interested in learning more about this. The one thing to kind of highlight is that we don't routinely use this within the first 7 days of life. Our group felt that until there was more evidence of safety in that period, we would refrain from using it in our small babies. So, like I've spent the last bit of time going over some of the evidence base, and again, to remember that it's not meant to be exhaustive by any means. Each of these topics is an hour-long talk on its own, but hopefully I've given you some flavor of what is the evidence to date on some of these different modes, how you may use them, what are the different types of indications for them, and you may be at a center where all of these modalities are available to you. So, what I had found is that sometimes it can be very confusing what to use when, knowing that there's sometimes very limited evidence to support its use. So what to actually do can actually be somewhat confusing. And that's why I'll leave you with some practical considerations on how to use it in your own unit, and with a very important note that there is no right or wrong way to use it, as long as you develop some way that's in a consistent way, so you know what is it that your center does. And that's what we endeavor to do at McMaster. So we have a bit of a unified approach to using these modes, because the technology has outpaced evidence, and we have all these tools and modalities at our disposal, and it can be rather confusing as to how to use them. So one of the things, and I'm not going to spend too much time on this by design, I did not go into interfaces too much today, but whatever interface you're using, it's important that you're using the correct size. So if you're using prongs, it should not pinch the septum or cause blanching of the nose. If you're using masks, it should not have a little bit of gap between the top of the mask and the nose's tip. There are fixation devices, so you may choose to have, look into what products are in your own area that help keep the interface, because one of the most important things is to actually keep the interface very close to you. And this is courtesy of Dr. Sani, who kindly allowed me to share these images with you. And then use of chin straps and pacifiers. I mean, pacifiers we use pretty liberally. Chin straps, most centers will not use it as a routine tactic, but there may be instances where you have to use chin straps. I will just ask that if you can please put yourself on mute, because there is a bit of a background noise there. Thank you. Okay. Thank you for sharing this. And another important issue is the infant care and positioning on non-invasive support. So no matter which mode of non-invasive support you're using, it's not going to work if the interface is not the proper size, if it's not been applied properly, if we're not making sure that it's clear and suctioned properly. And if these things are not done well, none of the non-invasive modes are going to work well. So the primary care person who's actually at the bedside looking after these babies needs to ensure that the interface is properly positioned, it's the right size for the baby, and we keep it suctioned and cleared as much as possible. to allow for optimal pressure delivery and whatever mechanism we're using, whether it's high flow, nasal high frequency, CPAP, or NIPPV. And always to ensure, and this has happened a few times where the humidifier is not working or the temperature is not at the right setting. So it's very important to make sure that we keep an eye on this and make sure that it's always heated and humidified. Now, with those things in mind, how do you use the 4 different modes that I've talked about? And again, I'll highlight that this is a suggested approach. You may have a different kind of an approach at your own center, which is totally fine. But this was one suggestion and how we model our thing at McMaster. So the primary use of NRS, so this is a baby who's just completed transition and needs non-invasive support. We will start them on CPAP, and we'll go up to 8 centimeters of water in a baby like that. Some centers may use NIPPV as a first-line primary mode, which is okay. And then what happens if that fails for a baby? Your options are either, if you're using CPAP as a starting mode, you may go to NIPPV. You may choose to go to higher CPAP pressures, but again, to have caution, and especially the first week of life, until we have more data on this. And our research group at McMaster is looking at this as our main area of focus. And also another option is nasal high frequency, again, with some caution in the first week of life. But again, over the next few years, as more data emerges, I think all of us will become more and more comfortable with it, may become more comfortable with its use early on. And of course, endotracheal ventilation at any time, with or without rescue, non-invasive use is an option. So that may happen at any point the baby gets really sick. Post-extubation, your options are either you go to nasal CPAP, and sometimes in chronic cases at our center, we'll use pressures up to 10 to 12 centimeters of water, but that's something you decide amongst your own unit as to what CPAP level you're comfortable with. Some centers will go routinely to NIPPV, and some centers will make a decision. They will say that for extubation from lower settings, we'll go to CPAP. If we're extubating from high settings, we'll go to NIPPV as a routine, and that's okay too. And in some cases, I think as we saw earlier, some centers will go to high flow in babies, particularly more than 28 to 32 weeks corrected age. And that's also an option. And again, as shown in the Cochrane review, and particularly for the bigger babies, high flow may be a suitable alternative to these other modes. In some people may use nasal high frequency as a post-extubation support mode. And again, we'll see more and more studies evaluating nasal high frequency compared to the other modes in this regard, and looking at things like failure of the assigned mode. So I think that evidence bases continue to build over the next years. But at our center for now, it's mostly considered a rescue non-invasive mode, meaning that we use it after other modes of non-invasive support have failed, and we're trying to prevent intubation in this group. And one of the final thoughts I'll leave you with is that, and this comes from the Goldsmith assisted ventilation of the neonate, and I think this is from Martin Kessler's chapter. It's referring not just to non-invasive, but any type of respiratory support. But I really like the sentence. It says that the single most important factor associated with safe and successful ventilator management of the neonate is the person operating the device, not the device itself. And I quite believe in that you can do a lot of different things with any mode of ventilation that you're on, but to use it properly is the most important thing, and not to quickly shift from one mode to another, but to really troubleshoot within the mode of support that you're using. And I think those principles apply to non-invasive support as well. And in particular, as I said at kind of the latter part of the talk, making sure that the interface is applied properly, that we've troubleshot the ventilator, that all the operations of the device are working properly before we say that something is not working about CPAP or NIPPV or whatever other mode you're on. So at the very end, I'll leave you with a couple of take-home messages. Sorry, it ran a bit long, but the one take-home message is that non-invasive respiratory support, and I would really encourage the use of this as the term, as a general term, as opposed to NIV, but that NRS consists of a variety of different modes, interfaces, terminologies, and is ever evolving. If I were to give the talk 2 or 3 years from now, this talk would look very different because we're going to have newer studies and newer modes even that have come up. And certainly more research is required because the available technology and the different options available to us have quickly outpaced the evidence on how to best use some of these modes and when to use some of these modes. So that's a bit lagging, and there needs to be work on this. And the best rescue non-invasive mode remains unclear. And one of the things that we have to be smarter at studying is that there may be certain underlying lung pathophysiologies or clinical indications in which one mode of support is better than others. And I think we're going to start to see that over the next many years, that's the way the research goes. For example, looking at apnea prematurity and how do we best manage that, as an example. And I personally think that it's this is a bit of a personal opinion, but I think it is important to have a standardized practice within your units, especially when we have so many different modes, interfaces, ventilators, all these things available, that it can become very confusing very rapidly. So to have a standardized approach within your unit, recognizing there is no best answer to this, but I think will help you understand how to best use this, what the limitations are, and learn these modes a bit better for your own clinical application and practice. And I think if that can be one takeaway from this talk today, I think that would be good. And with that, I'll end it here, and we'll happy to take any questions or comments. Also, I'll leave my email address here if anybody wants any of those guidelines or any questions that pop up later. Always happy to address them. Thank you very much for your attention.
And Rajesh, over to you. Please take the question.
Yeah. Excellent talk. And as usual, the most people have asked about the interface of choice. Which interface is better for the CPAP? Short binasal prongs, nasal mask, or AMS cannula?
I just noticed that Dr. Ram has just left the meeting, so he is probably best equipped to answer this question. One of the things, and I think Dr. Ram will acknowledge this, is that with the RAM cannula, one of the things we have to be careful with is that there's a high amount of resistance in the circuit. So there is a bit of a pressure drop off when we go from the ventilator to the interface. So one of the things we have to be careful about is that when using the RAM cannula, you may have to use higher pressures to deliver the same flow of air into the baby. So that's one comment I'll make. With regards to short binasal prongs and masks, there's some evidence that masks may yield better delivery of pressure, and there are some systematic reviews on the topic looking at this issue. I will say that practically, it's really difficult to use only one interface. If you're using the short binasal prongs or the masks, most centers will actually alternate them, because if you just stick to masks and masks only, you will over time start to see problems in the nasal bridge of the babies. Similarly, if you only use short binasal prongs, you may start to see problems with the nasal septum. So we find that practically, kind of the evidence piece aside, practically speaking, that probably doing a switch over where you give the nasal septum and also the nasal bridge a bit of a break is actually the way to go. So I think my own recommendation would be that to kind of use both in an alternating way, and there will be occasionally some babies in which the nasal prong simply doesn't work because their nerves are so small. So when we have the extremely small babies who've just been intubated, we're not intubating them, we find that we just don't have small prongs small enough to actually fit the baby's nares. So in some cases, some of those cases, we're just left with just using the mask. In some other cases, conversely, we find that the mask may just occlude the nares enough that it simply doesn't work well, and it's actually the prongs that work better for these babies. So I think it's it's not a simple answer. But I think you have to look at the baby itself and see which interface is better for that particular baby. But if you were to just look at the evidence base, it appears to be that the mask may have better pressure delivery compared to the prongs.
You told that you alternate the mask and the prongs. What is the protocol in a unit? How frequently you alternate it? 6 hourly, 8 hourly, or every other day? So it's a good question. So sometimes it'll depend on the baby because our handling times are very infrequent for the small babies. So some of the smaller babies will only handle them every 12 hours. And in those times, if baby ears are big enough, we'll switch over to the other interface. For some babies in whom we handle them more frequently, we'll change them every 24 hours or every, sometimes even as frequently as 6 hours if you're noticing that there's a problem with their the septums or their bridges. Really related to same, like we all know that nasal trauma is major complications related to the interface. So what is the protocol in your unit for nose care, apart from this alternating the prongs and the mask? Any other way in which decreases the trauma?
Yeah, good question. So, so there are, I guess I would say there are three major strategies. One is that we will alternate the masks and the prongs as mentioned. We will sometimes try high flow earlier on these babies. So if there's a baby, let's say at 29, 30 weeks who's significant trauma, even though our own internal policy is not to use high flow to 32 weeks, but for significant trauma, we'll sometimes use high flow early. In the rare cases, we will intubate the baby and give their noses a bit of a break. And we use this product called a cannulate. And I can show you the picture of it. I think it was on there earlier. I don't know if everybody can see the slide still. But one of the products we use, and again, you have to look to see what products are available to you. But this particular product, if everybody can see my slide still, you will see that it's basically like a plastic material that covers the nasal bridge as well as goes around the septum. And we can use that to kind of create a bit of a cushion for both the mask and the septum while allowing to maintain a seal. So this cannulate product is something that we found pretty good success with.
Over to Murki.
Dr. Amit, Dr. Amit, there are some questions. What all do you do to prevent failure? Because you did say that if the baby fails, you go to nasal IMV. So what all is done to prevent failure apart from changing the mode?
So if I understand correctly, if the question is about failure of non-invasive modes themselves, I think the main thing is to make sure that we have proper, nasal and oropharyngeal care, and that we're using the right size interface and the right kind of device for the baby. So if you're confident that the interface is proper, that there's no significant leak around the interface, in rare occasions, we use a chin strap to maintain the pressure if we really feel that we want to avoid invasive mechanical ventilation in the baby like that. I think that's, those things are important to make sure that at least the nasal interface and pressure delivery is as optimal as you can. And if that piece is done, and on occasions, if you've tried the chin strap to maintain pressures as best you can, then really the next step is to try the different modes. At our center, what we often do is if on CPAP or NIPPV, we optimize the setting, we make sure we're happy with the interface, the pressure settings that we have chosen. We either go up on the CPAP pressures, sometimes we'll go up to CPAP pressures of 14, 15 centimeters of water. But if that doesn't work, we'll try nasal high frequency. When we had done our case series between Hamilton and Toronto, the three centers in Toronto and Hamilton, we found that in such instances, when we use nasal high frequency, more than half the time we were able to avoid invasive ventilation when looking at this over the next 7 days. But it was not a controlled study, so that has limitations. But we have found some success with that, at least in delaying intubation. But aside from that, there's no other particular thing that we use. One of the things we do often, rely on is like an a priori for what's considered failure, because I think sometimes people struggle with that. And we have generally said that we will tolerate FiO2 of up to 60%. And then if the FiO2 goes above 60%, that's a discussion whether that baby should be intubated. And different centers will have different thresholds for what is considered FiO2 at which they would like. Sometimes it will be lower, sometimes it will be higher. I'll say one thing, that for a baby who has not received surfactant in the first 3 days of life, our FiO2 threshold is very different. We will be very liberal in intubating and giving that baby surfactant in the first 3 days of life, if they're still in that window where they need surfactant. So for such a baby, we will not wait, about 25, 30% before giving them surfactant. So hopefully I've touched on the question from last year.
So I understand that you said about the surfactant. Are we talking about Insure or Lisa, or what is the indication? At what time you start doing Lisa or Insure?
Yeah, so it's a good question. So, at our center, we don't yet use Lisa, but other centers do. Regardless of how you give the surfactant, our internal criteria would be that for a baby who's less than 28 weeks, our maximum CPAP is 8. We do not use NIPPV or nasal high frequency or any other mode. Our maximum CPAP is 8. And if despite that their FiO2 is rising, or they're having worker breathing, or if it approaches 30%, we will give them surfactant by whatever means. In a few years, in a year or so from now, that might be by Mr. Lisa, but for now, it's insured.
So, but if the baby requires surfactant, you will continue on CPAP or you do shift to ventilation?
We will, if it's determined that the baby requires surfactant, we will give them surfactant through insure at our center.
What about the newer technique of CPAP? The immersion angle is tilted.
Yeah. So that's missed. So minimally invasive surfactant treatment or less invasive surfactant administration. So the evidence does seem to suggest there's still limited data between MIST and INSURE, but the limited data till date suggests that MIST or MIST is probably a good approach to prevent BPD and to limit the number of days on invasive ventilation. But the quality of evidence is still rather limited. So I think if somebody's interested in doing that, they can, we can talk about that separately. But I think at our center, we're still kind of refraining from it. But I think in a couple of years from now, we will head towards the use of it. Our national level.
My question was on bubble CPAP. The new DBLASI study where the immersion, the immersed tube is not straight, but it is at a degree of 45 degrees. Or
I see. Okay. Sorry.
What is the take on that to prevent CPAP failure?
Yeah. So I have to be honest. So that particular, I'm familiar with that new device that I think it's Draeger that's marketing that product, but I actually have not myself seen any studies on it. But I have to be completely honest. I have not sought out that in detail either. We had just finished our systematic review on bubble CPAP last fall. And as of that time, there was no studies published on that particular mode. So unless something has come up in the last few months, I'm not aware of any studies that has evaluated that. But if somebody knows of any studies, please let us know. So I can't really comment on that any more than that. Sorry.
The other question was, what is the lowest gestation at which you keep trying the nasal invasive mode of ventilation, whatever with it? Do you have a cutoff beyond which you don't try NIV and go directly for invasive?
It's a very good question. Now, we have a certain practice at our center, which has a variety of factors that go into it. So at our center, we prophylactically give surfactant to anybody who's less than 26 weeks gestational age. So 25 weeks and below, we give prophylactic surfactant, and we give that using mechanical ventilation. So at our center, the practice is that 25 weeks and below, everybody gets intubated, gets surfactant. There will be the rare exception of babies at 25 weeks who look, let's say a baby is 25 weeks and 6 days who looks really well. We may try CPAP on them first, but everybody else gets intubated. That practice is a little bit different than a few years ago, because a number of years ago, we were doing CPAP for everybody, even 24, 23 weeks. We were starting them on CPAP. But what we found is that at our center, all of those babies, virtually 100% of those babies were getting intubated anyway. So we said, we're just going to intubate them and give them surfactant. That's our local experience. So I can't really speak to what other centers do, but I know that there are many other centers in Canada that do routinely intubate for surfactant administration, but that landscape is changing now because of MIST and LISA. Many centers are now giving CPAP or NIPPV and just giving surfactant through the catheter and keeping them on non-invasive support. So with the introduction of LIST and MISA, that has changed a bit, but I think if that's not being applied, you kind of have to look at your own center's experience and data and see what works. I know there are centers that successfully do CPAP even for 24 and 23 weekers for some time. But keep in mind that in the COIN trial and the support trial, if I use the support trial as an example, so support trial was all babies were started on CPAP and given surfactant if need be. But in that trial, remember that 80% or higher of babies actually received surfactant through intubation. So I think the key message is that, no matter what cutoff you choose, if you use CPAP as a starting point, to have in mind what will be the cutoff at which we actually end up giving surfactant, and not to keep them without surfactant for too long, because that can be detrimental. And you'll all remember from the COIN trial that there was a higher rate of pneumothorax in the babies who were trialed on CPAP, and the belief was that a high level of pneumothorax was because those babies did not get surfactant, and some of them probably could have given surfactant sooner.
Amit, you talked about the lot
There is
of
one
other.
question. Can we use the? Carry on, Rajesh.
Yeah, you talked about the pressures giving more than 8 on CPAP. There are a lot of questions about apprehension regarding the CPAP giving more than 8. What is the cardiac output, and what is the perfusion, and what is the incidence of pneumothorax once you give CPAP more than 8?
Yeah, thank you for that question. So I think the one thing I'll say off the top at the very beginning is that, many of us are very comfortable using NIPPV, where the mean airway pressure goes quite a bit above 8 or even 10 sometimes. So again, just to keep in mind that we are sometimes delivering those non-invasive pressures anyway. The same thing with nasal high frequency. If you look at the published data on nasal high frequency, the mean airway pressure is often 10 or 12 or even higher. If I can, share my slide again, I don't know if my slide shows up, but we have done some studies looking at cardiac output with high CPAP pressures, and we did find that both compared to NIPPV and also in CPAP alone, going from 5 to 13, the cardiac output appeared to be relatively preserved. Now, this is by no means definitive, because our study from published last year was on a very small group of babies for a very short period of time. So how this relates to longer periods remains unknown. I can tell you anecdotally that at our center, we're actually have been using high CPAP pressures quite a bit and have found it relatively successful. And we almost prefer to CPAP rather to NIPPV, because we don't have those peaks in pressure where you send all of this air into the stomach suddenly. And we find that using higher CPAP pressures in some of our chronic babies, CPAP of 12, 13, 14, we've had no problems whatsoever with it. There's been no issues with pneumothoraces. There's been no problems with kind of cardiac output or perfusion. We're actually doing a study, a pilot RCT comparing high CPAP and NIPPV. We've completed 30 babies, and there's been no adverse events from that so far. So I think it's something that's going to become more apparent over time, and I think as we get more experience, we'll get more and more comfortable with it. But I can talk about that in more detail if anybody's interested, and share our guidelines and experience with it.
You told that
question, how do you use leak compensation when using non-invasive respiratory support, and how will you allow? How much you will allow that?
So leak compensation is, like I guess inherent in the device, and that the devices that we use automatically adjust their flow. So the devices will have, and granted measured on the machine end, that the devices will look at what pressure is being generated or what it thinks is being generated, and if the pressure generated is lower than what we have set, the device will automatically increase the flow to a certain extent to try and compensate for that leak, and to try and make that pressure go higher. But despite increasing flow, if the set pressure is not reached, then the ventilator will start alarming that the set pressure is not reached, and then it's up to us to decide how do we compensate for the leak that's happening at the mouth. Do we put a pacifier in? Do we put a chin strap? So to a certain extent, the ventilator can compensate for the leak, but I would say not entirely.
What is the pain management you use for babies on NRS?
Pain management? So pain management, we don't have any
do for babies on NRS.
Sorry, pain management, correct? So yeah, there's no particular pain management we do. So in other words, we don't routinely give either analgesics or sedatives to babies on non-invasive or even invasive respiratory support for that matter. So we don't have any routine policy for that. And I will say that for non-invasive, I don't think we need to use it. At our center, we manage them without sedation and analgesia quite well.
A 32 weeker on CPAP with pneumothorax and ICD in situ. Can we use nasal HFO?
Let me put it this way: there's no reason why you can't. There's nothing about the nasal high frequency that's going to make the situation any more risky. I think anytime you have a baby who's sick enough that has an intercostal drain, you have to be careful that baby could get sick at any point, no matter what kind of mode they're on. I'll say one thing though, I would much rather have a baby like that with a pneumothorax with a drain on either CPAP or nasal high frequency than NIPPV, because with NIPPV, the worry is going to be with those peak pressures, you might, send air into that into the intercostal space, the pleural space, rather than CPAP or NIPPV. So like I don't have any data to back it up. Generally at our center, if a baby is so sick that needs an intercostal drain, we usually have those babies intubated. So that's our general practice.
Coming to
Yes, go ahead, Dr. Rajesh.
yeah. Coming to nasal high frequency, there are a lot of questions regarding the machines. Which machines do you use, and any difference between SLE, Dragar, or Stephen, or made in any experience?
Yeah, so at our center, we use mostly the Dragar VN500 to give nasal HFO. However, we have also used the newer Maquette servo products. So there's a Servo N by Maquette. So we have recently acquired a few of those, and we've used nasal high frequency using that machine as well. And we've also used the Babylog 8000, which is the old Dragar. So in our experience, it doesn't, to us, there's no clear winner, quote unquote. I think any device that can do invasive HFO, you can just rig it up to give nasal HFO. The only machine that we haven't used for nasal HFO is the SensorMedics. And partly because the rigid is so circuit, and we have not been, and partly because we haven't had to, but we haven't, been able to connect our nasal interfaces to the rigid circuit that the SensorMedics comes with. But of course, somebody could make something and do that. The only thing I'll caution about the SensorMedics is because the rigid is so circuit, the circuit is so rigid that you'll have to be pretty careful about what amplitudes and frequencies you're using, because we know that in the SensorMedics, the VTHF, or the volume transmitted, is actually higher than a lot of the other machines. So apart from that caution, like it doesn't matter which particular thing you're using to deliver nasal high frequency, as long as you can connect up all the interfaces and make it work.
And which interface do you prefer?
We've used both. We've used both short binasal prongs and also nasal masks. We have not used the RAM cannula. I know some centers, like Sunnybrook, for example, they have used the RAM cannula with nasal high frequency. The only thing about RAM cannula would be that if you're using it, you'll just have to adjust your settings. Like I said before, you'll have to use much higher amplitudes on that to generate kind of the visible or palpable shape at the level of the chest.
And how much maximum pressure you go, MAP, on nasal high frequency?
I mean, we've used locally at our center pressures of up to 15, 16, as you saw in that video, are not uncommon at our center to use nasal high frequency. But again, our indication is different. We're using it on babies as a rescue mode. So these are babies who have failed CPAP, who failed NIPPV. Like I would not suggest those kind of settings if you're using nasal high frequency as a primary mode. As if you're using it on a fresh baby, a fresh 28-week baby, then my suggestion for MAPs would be that whatever MAPs you're using, comfortable using on CPAP, use those, or maybe 1 or 2 points higher. That would be the recommendation for MAPs.
Murki?
I think there are many more questions. I think it has been an excellent presentation. I think this is never-ending topic, but I think he has given a gist of all the relevant things for non-invasive ventilation. Thank you, Dr. Amit, and thank you all the delegates, and thank you IAP Neocon as well as the IAP chapter of NLF chapter of Kerala. Thank you, Manoj. Over to you.
Well, thank you so much, Dr. Amit. It was such a wonderful talk, and we had excellent discussion thanks to our moderators. Friends, this is the 4th webinar in our series, and we are truly humbled by the kind of support that we are getting for this series. Kindly join us for the next webinar in this series on 15th August on slightly different topic, different from the usual topics. It's on medico-legal implications of neonatal practice by another legend from Canada, Professor Dr. Sumesh Thomas. May I now request Dr. Muraliraj to officially propose the vote of thanks and wind up this session. Thank you.
Hi, friends. So we can call it as a day, and Dr. Amit Mukherjee has taken us to various aspects of non-invasive ventilation and NIPPV and nasal HFO. So thank you, sir. Thank you, sir. for enlightening us about the various aspects of non-invasive ventilation. And in the outset, I also like to thank Dr. Srinivas Murki and Dr. Rajesh Kumar for excellently moderating this session. I think almost all the questions were analyzed, and we were able to get a reply from Dr. Amit Mukherjee. And it is seen that more than 600 delegates were there all over the globe, and we had more than 500 in the Zoom and more than 100 delegates in the YouTube watching our program live. So I would like to thank all the delegates from all the entire globe for supporting us and gaining knowledge with us. And also I would like to remember you that our next program is on August 15th at 7:30 p.m. Indian Standard Time. And the speaker will be Dr. Sumesh Thomas from Canada, and will be dealing with the medico-legal aspects of neonatal care. Thank you. Thank you for your wonderful interaction and a wonderful program. Thank you. Good night.
Thank you very much, everybody.
Thank you. Thank you. Thank you, everybody.